paper. So the first one we wanted to discuss is the paper published in the European Heart Journal of Cardiovascular Imaging, and it's by Bharath, Ambale-Venkatesh, and it's called Association of Myocardial Fibrosis and Cardiovascular Events, the Multi-Ethnic Study of Atherosclerosis. So, this paper, and to be honest, I know Bharath is online, so that's great because that paper confused me a little bit. The background of the paper is that we would like to have more data and a good understanding how myocardial fibrosis is associated with cardiovascular events. And someone is sharing the screen. Okay, great. Wait, who is that?
It's Elizabeth.
Okay, great. Liz, thank you for helping me out with that. So that paper is going back to the MESA trial, and if you just zoom out a little bit, if possible, Liz, and move a little bit down. So that paper is reporting data from the MESA study, and the MESA study is a well-known study going back 20 years with 6,800 participants, and it's about atherosclerosis, and a lot of imaging involved in that, also CMR. And this paper looked at the data of MRs acquired 10 years into the study. So this is an MR, and then looking back on how the actual findings now are associated with previous events. So the authors, of these 6,800, so in the population it actually says 3,000, but the results are reported for 1,840, are using a standard protocol that includes late gadolinium enhancement imaging and mapping using a MOLY sequence. And what they did with that, and they did the mapping before and after contrast, they quantified post-contrast MR, T1, but also the extracellular volume fraction. And they used that as one of the first papers reporting that, although it has been reported before. They report the synthetic hematocrit values derived from the T1 maps. So what they found, if you go to the results section, what they found were in these 1,814 participants that 156 of them had cardiovascular events. And so then what they found when they correlated that with the actual MR, they found a few known risk factors to be associated with that. So if you go to table 1, please. And to make the long story short, there was nothing really that surprising. So the usual culprits, hypertension, dyslipidemia, pack years of smoking, GFR, and all that were associated with the events. It was a little bit surprising that if you go to table 2, that if you compared those with and without events, that the absolute difference was fairly small for a lot of the markers. And of course, with the number of participants, you're still significant. But it's not that you could find anything remarkable in terms of a huge difference. The presence of a scar on late GAD imaging, of course, we know that is associated. So it was clear that these patients with scars had events during the follow-up period. But I found it interesting that the pre-contrast T1 was exactly the same between the groups. There was still no difference. This is a little bit in contradiction with some other papers reported recently. So in order to basically summarize the main message of this paper is that nothing really surprising. Late gadolinium enhancement derived scars are associated with events in the past. The data for the mapping here were not terribly striking. However, there are a couple of limitations to that paper. That's why we probably have to take it with a grain of salt. The MESA population was so basically acquired, so started 20 years ago, were people where we knew that they did not have cardiovascular disease. So it is a somewhat more healthy population than you would see in your clinic as a cardiologist. So that's one thing to remember. And then regarding the T1 mapping, I'm not entirely sure why there was no difference, and that would be the first question to Bharath, whether he has any idea why the T1 mapping, the native T1 map, didn't show any difference at all. So I don't know if you could unmute yourself and have an idea, and also share with you your personal experience with the data and how you see them fit into what we know from other studies.
Oh, sure. This is Bharath here, so I'm glad to speak about it. So I think one of the main reasons why we set about doing this study initially was to look at specifically because we were interested in inflammation and fibrosis, and we know that with cardiovascular events, there's acute inflammatory increase in inflammatory markers. And while we didn't necessarily look at the markers themselves because we didn't have those during when the events happened, we found that, for example, that ECV is higher. It's not terribly higher by a lot, but it's high by about 1.5%, which based on other papers, I think that adds, where even 1.5 to 2% higher fibrosis, it relates to, quite a bit actually in the end. It's almost 50% higher likelihood of events. So that was the reason why we looked at it. But I think why pre-contrast T1 itself was not associated, which was a little surprising to us as well, which I should admit. We thought it might be because it reflects more or both extracellular and intracellular volume expansion, and maybe there's a little bit of non-specificity when it comes to pre-contrast T1. That might be the reason why it's not significantly different between the two groups. While ECV being more specific to the extracellular space, I think might be the reason. That was one of the reasons we thought it.
Okay. Okay. Thank you. Are there any questions from anybody?
Well, Andrew Arai here. I'd like to make a comment. When you have an event rate that's so low, you're averaging out so many people that don't have events. Doesn't that make it very difficult to see group average differences in the T1s and the T2s? That's one thing. But the other side of it is the subtlety of changes in ECV are things that you can see in a population study and get insights into some underlying pathophysiology. But when the differences are this small, it makes it difficult to translate to diagnostics. So for example, the shift from an ECV of 26.9 to 28.5 is less than a standard deviation, and therefore going to be within the normal range. So it'd be hard to use those for diagnostic purposes.
I think that's a great point. And I have also one additional question. The conclusion says here, individuals who suffered prior CV events had greater likelihood of diffuse myocardial fibrosis. It doesn't talk about regional fibrosis, and it also talks about living in the same community. So I was a little bit confused. Is the conclusion, because the actual conclusion later in the paper sounds a little bit different. That refers to the regional fibrosis too.
Yeah, I think in our case it was both a little bit, but I think the fact that focal fibrosis is also higher or occurs higher is known before, and that was one of the reasons why this training was more about fibrosis. Okay,
so thank you very much, and now we'll move on to the other paper. So it's published in JAMA Cardiology, and Liz has already fired it up. And it's by senior author is Andrew Arai, who's here with me at the NIH in Washington. And it's called Association of Unrecognized Myocardial Infarction with Long-Term Outcomes in Community-Dwelling Older Adults, the ICELAND MI study. So this is, I think, a very important, a landmark paper looking at data from this ICELAND MI study, which is in so far a very excellent population, because the people in Iceland, not only that their healthcare system allows for tracking them, but also it's a genetically fairly homogeneous population that allows for looking for confounders, and also the data from such studies are likely to be fairly clean, therefore from other influences. So they were interested in something that had been reported before, unrecognized myocardial infarction. And a couple of years ago, Eric Shelbert, don't know whether he's on the call.
He is.
Great, I hear he is. Hi, Eric. Published one of the key papers, one of the first, showing that unrecognized MI is actually, so small ischemic scars is actually not that infrequent, and this has a prognostic implication. Now, what this study did was exactly looking at that. What is the long-term prognosis of unrecognized myocardial infarction? So as a cardiologist, the background is very important to us, because does it make sense to look at MIs people don't know about? Usually I'm a cardiologist saying, okay, leave people alone if they're doing well. But if we would know that an MI that has not shown up clinically, people don't know about it, would have a prognostic impact, then that would trigger potentially very efficient primary prevention with certain drugs, specifically aspirin and statin. So that is very important, and that's what these authors did. So they looked at a subset of the ICELAND study population. The total population is close to 6,000. And between January 2004 and 2007, they recruited these people that were included here, and also performed next to an MR, a cardiac CT, for calcium scoring. The MR studies were done at a 1.5 Tesla scanner and included a standard protocol, including late enhancement imaging, between 6 to 25 minutes. Now, that seems like a fairly big range, although from my clinical experience, anything after 8 to 10 minutes I typically found very useful. So the vast majority of the participants here probably were studied in the golden window for late GAD imaging. So the hard outcomes were defined as it's correct as all-cause mortality, and a secondary outcome, MACE events like non-fatal MI, heart failure, and then a composite endpoint of mortality, MI, and heart failure. And the good thing is that in Iceland, as I said, so the national database allows to track deaths, hospital stays, and all that. So that, of course, ensures the good quality of the data. The mean age of the, now that's important, was 76. So it's a rather elderly population, older than what people see in the hospital. The mean range for infarct patients, for example, is between 55 and maybe 60. So this is a somewhat elderly population, but this is the population that shows up and will show up, especially during the next years, with a good treatment of acute diseases in the emergency rooms. Now, looking at the results, they looked at the unrecognized MIs, or UMI, and the recognized. And the first interesting thing was that the unrecognized MI was more prevalent than the recognized, so 17 versus 10%, which is important. So UMI is not infrequent. It's actually in that cross-sectional population is more frequent than the recognized MI. So that's the first very important finding from my point of view. And then what they could see that the recognized MI, because they are treated fairly well there, they had lower smoking rates, lower cholesterol levels, and also took more of the medication known for primary prevention. So they actually did a good job after knowing about their MI. Now, looking at the MR data, the left ventricular ejection fraction was okay in all of them. The recognized MI, they had a slightly lower, it's 53%. The unrecognized MI population had 60%, the other 63%. And so that it was not hugely different there. And looking at the outcomes, and that was a follow-up of roughly 10 years, and there were over 400 deaths, so that's a very good number to make statements on mortality and on hard events. Now, the second interesting finding was that the unrecognized MI had similar, in fact, the same mortality rate at 3 years, but was lower at 5 years. But then looking at 10 years, again, the mortality rate was 49 versus 51%. So in other words, it doesn't really matter after 10 years whether your infarct you had was recognized or not. It's the same prognosis. And that is, I think, extremely important. Now, if we go to table 1, there's an overview of the associations in the groups of unrecognized and recognized infarction. And so interesting to me was that the risk factors, they were, of course, we knew that if you have more risk factors, you're more likely to have events, and that's also true for unrecognized MI. Then, as I said before, aspirin and statin was more used more often in the group with the recognized MI. In looking at the bottom of the table at the imaging, the two I want to point to is the coronary calcium, because that showed quite a big difference. So there is always debate about the utility of calcium scoring, but these data certainly support a prognostic value of the calcium score. The ejection fraction, as I said, was not hugely different to some extent. So when compared with the between recognized and unrecognized MI, as I said before, the risk of death was actually the same. It's statistically not different. The higher hazard ratios for mortality in the unrecognized group were especially there for men and for diabetes. Whereas in recognized MI, it was different, but that's probably due to the therapy and the other measurements. Then participants younger, and that is important for people like me, younger than 70 appear to be at the highest risk of death from unrecognized MI. So if you go to the figure, here you can see the interesting course over the years that in the left upper quadrant, the all-cause mortality is higher up to 4 years in the recognized MI group, but then the unrecognized MI, basically the curve catches up, and then after 10 years, it really doesn't matter. So then table 2 just provides a comparison, but there is nothing much more above what I already said. So the authors conclude rightfully that unrecognized MI detected by CMR has a similar long-term mortality risk as recognized MI, has a higher risk of death, MI, heart failure. So, which means that if you see something MR, then your patient has definitely a higher risk for not only some events, but for the heart events. And it's particularly important that unrecognized MI is more prevalent in that population than recognized MI. So it is a health problem that should be focused on more than we did before. Now, of course, the question now for clinicians and clinical researchers is how does that translate into primary prevention or secondary prevention strategies? Do we have to actively search for people with that risk and then treat them? And if we do that, can we improve outcome? Can we basically stop the progression? The data here, I think, support that, but of course, we will need some final proof. So I want to congratulate the authors for this excellent study, for this wonderful paper. I bet there will be probably more to come from the ICELAND MI study. But first of all, a question to the authors, and since Andrew's sitting next to me, but Eric, feel free to chime in. The protocol, I bet, had more than LGE. Did you use other techniques, maybe even mapping to look at additional potential prognostic markers?
This study was done quite a long time ago, so pre-T1 mapping dates, but it basically was CMRI and late gadolinium enhancement.
Okay. So, Eric, you kicked off the ball of unrecognized, at least recognizable to me, a couple of years ago. what is your overall assessment, having thought about this entity and its role in clinical cardiology? How do you use that in your patients?
Thanks, Matthias. Boy, where to begin? I think practically it just comes down to more liberal statin use. I think people, thought that the original paper was sort of advocating for screening, which I don't think is the case. But clearly stuff is happening beneath the clinical radar screen that clinicians need to be aware of.
Yeah, and
so I think it's sort of like a failure of prevention of atherosclerotic events. And, this to me is the biggest argument against, sort of Rita Redberg's position that primary prevention doesn't work with statins. So, it's sort of a leap of faith that, statins would prevent unrecognized MI. But, when you have a patient in your clinic, what call are you going to make? I would intensify statins, until further data come out to, sort of disprove that hypothesis.
Yeah. No,
I think that's the practical, the practical implications of that, and then also the prevalence that there's a whole lot of clinical activity that's missed, with our usual patient interactions.
Yeah. No,
I think that's a huge deal.
Yeah. I would agree with your assessment. I'm also not a friend of widespread screening strategies because we may not be able to afford that. We do not know how to deal with incidental findings. And
right.
aside from this observation here, that late GAD seems to be a very good, or SCAR seems to be a very good predictor. Not many of the others have been, let's say, are as good candidates for an actual active primary or secondary prevention. But on the other hand, it also could mean that once a patient has some clinical evidence and the CMR shows an unrecognized MR, that we probably have to take that as serious as a regular MI and treat this patient as aggressively with medication and, of course, more importantly, lifestyle optimization. Yeah. Okay, any other questions from the audience? I already stole 15 minutes of your lifetime, so I'm sorry for letting you wait. So then, if not, I want to thank everybody for participating. Thank Andrew and Eric and Bharath for the discussion. And I want to point to the next CMR Journal Club that will be not right after this CMR because we may still have a hangover of MR data. But a week later, that is February 19, we will discuss two papers. And this journal club was mainly about a clinical application of CMR. The next one will be more methodological. And the two papers we will discuss, one is from Judy Liu. It's about oxygenation-sensitive MR showing a transmural gradient during adenosine perfusion. So that means that the oxygenation in the myocardium was found to be unevenly distributed. So that's interesting. And then the other one, a paper by the Inselspital in Bern, Dominic Günsch. It's an observation of physiology in vivo, looking at the relationship of myocardial oxygenation and blood pressure. So what they could show is that indeed, and this is an experimental study, that the blood pressure levels actually have an impact on myocardial oxygenation. And it's fascinating to see how low and high blood pressure directly affect oxygenation. So that was a very nice experimental study. So we will discuss these two papers next time. And thanks everybody for joining, and spread the word, and wish you a good day or good evening, depending on where you are. And see you next time.
Thanks so much, Matthias.
Okay. Bye.